So I want to welcome everybody. This is our first Thursday evening series in, fall of 2024, at the start of the school year. And we're really excited. We looked at topics for this year. We're calling them the other elephants in the room. So topics that, along with talking about death and dying, can be challenging and difficult conversations to have. So without any further ado, I'd like to introduce Catherine Hopkins. She's a registered nurse with a specialty in sexual health. And I had seen that Catherine had did a presentation for the Alberta Hospice Society, was it last year, Catherine?
Hospice Calgary. Yeah.
Hospice Calgary, yeah. And my interest was certainly tweaked by the topic. And so we're really fortunate to have Catherine here from sunny Calgary. I'll turn
Yeah.
things over to you.
Perfect. Thank you so much. Well, hi everyone. I'm really excited to present with you tonight. And yeah, like Val was saying, feel free to put questions in the chat throughout my presentation, and I'll try and answer as best I can. So let's get going here. So just before we start, there's a couple slides kind of to confirm I don't have any conflicts of interest to declare for this presentation. I am an employee of Alberta Health Services. This presentation is not affiliated with my role for them. And I have not received any financial or in-kind support for this presentation. All right, so just to open, a brief land acknowledgement. So as a settler in Canada, I live on stolen land. Colonization is ongoing, and it has really significant negative health effects or negative effects on health outcomes for Indigenous people and communities. Um, I would really encourage everyone to take a look at the Land Back report from the Yellowhead Institute. So that addresses land dispossession in Canada, talks about some meaningful Indigenous-led solutions. And then here I've also included a couple of Indigenous specific palliative and cancer care resources. This first one, Indigenous Cancer Health, is from Alberta Health Services. So that has a few links to information and services within Alberta for Indigenous patients and families, which includes the really wonderful Indigenous cancer patient navigators. And then the last one here, the Center for Education and Research on Aging and Health at Lakehead University, has some great resources for palliative and end-of-life care that are aimed at folks working with Indigenous people and communities. And actually, just as a note, like there are quite a few places through my presentation where I've included links to outside resources. So I know that can be frustrating when you're in the audience because you can't actually click on anything. I have tried to always include enough information that you can easily search for the content on your own. Feel free to take any screenshots, make notes of anything you want to look up later. But also, if you want to reach out to me directly, I'm happy to provide you the slides themselves or any specific links that you're looking for. All right. So Val already got us started here. My name's Catherine. I'm a registered nurse. My pronouns are she and her. I've recently completed the University of Alberta Graduate Certificate in Sexual Health. I've been working in nursing for about 13 years. I've worked in a lot of different areas, so that includes palliative care. I've also worked in addiction, sexual assault response. I currently work in sexual health. This is my email address here, is catherine.hopkins@ahs.ca. Please feel free to email me if you have any questions or if you're looking for any further information. I also let Val and Tara know I do have two cats who like to get involved in my presentation sometimes, so you might hear them in the background, but I'll try and kind of keep any disruption to a minimum. All right, so just some learning objectives. At the end of the session, participants should be able to discuss definitions of sexual health, explain the role of sexual health in palliative care, provide examples of strategies for incorporating sexual health into palliative care assessments and interventions, and identify resources for further learning. Okay. I'm sure a lot of you have a good familiarity with palliative care as a field. So I'm just going to start with a very brief review before we dive in. Some of the key principles involved are, palliative care is a specialized field that involves caring for patients and their loved ones who are affected by life-threatening health concerns. It aims at relieving suffering. So whether that's physical, psychological, spiritual suffering, that's all included. And of course, has that quality of life focus that emphasizes treatments and management strategies that improve day-to-day living, as opposed to focusing on curative treatments. Okay, well, I'd love to start by opening this up to the group, just getting a few perspectives on the question. So, what is sexual health? Um, just the nature of sex and sexuality, sexual expression, all of that means that these can be some tricky terms to define. They can have different meanings to each individual, to each relationship. I'm going to discuss some general frameworks, but please feel free to throw a comment in the chat if there's anything you want to contribute to start us off with. I know it might be a little bit intimidating kind of question to start with, so I'll kind of carry on. But yeah, if there's anything that anyone wants to chime in with, please feel free. In the meantime, I'm going to start with the definition that's provided by the World Health Organization. Sexual health, when viewed affirmatively, requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences free of coercion, discrimination, and violence. If there's no comments to throw in here, I'll carry on. All right. So just for simplicity, I've kind of broken my approach to sexual health down into three main themes. So these are medicine, pleasure, and safety. Many people who are in palliative care experience some level of chronic and/or acute pain on a regular basis. So that obviously can be a hindrance to pursuing sexual activity or sexual pleasure. Um, Palliative care patients are likely to be taking multiple medications or undergoing treatments, and those can have side effects that affect their sexuality in expected or unexpected ways. And then, of course, there are potential consequences of sex like STIs and pregnancy that can remain a concern depending on the individual who's involved and the relationship. And pleasure. Pleasure is essential to sexual health. So for me, pleasure really is what we're talking about when we talk about sexual health at end of life. We're going to get deeper into this in a little bit, but I just want to highlight a few pieces first, and those are enjoyment, adaptability, and normalcy. So we'll be discussing kind of allowing the idea of sexual health to be more expansive, rather than being limited to, like, for example, sexual intercourse, orgasm. And so, like, this idea of enjoyment, I think, is really key to that. Where we're coming from a palliative care perspective and just aiming to enhance quality of life for patients and families, centering enjoyment is really valuable. Um, Along those same lines, adaptability is pretty key for me as well. Everybody experiences changes in their bodies, our sensations, our interests over the course of a lifetime. So it's really important to remain flexible. Just understand that from one day to the next, from 1 minute to the next, what's pleasurable and what we take joy in may not always be the same. So for people who are in palliative care, living with and adapting to those changes is really their reality. They don't always get the support that they need from their care teams. By bringing sexual health and pleasure into more conversations about palliative care, we can continue to improve overall wellness at end of life, and just offer more options and more support for this idea of living until we die. And following that thread, just for some people, engaging in sex or engaging with their sexuality can be something that brings them back to a sense of normalcy and a sense of themselves that otherwise can really feel out of reach when life revolves around treatments, appointments, medication, and illness. Safety goes hand in hand with pleasure. In order to get the most out of pleasurable experiences, it's really important to be able to feel safe and secure. This really comes in many forms, whether it's feeling safe from physical violence or assault, or just feeling safe to share your secrets and share your desires with another person. Uh, our attitudes towards sex and sexuality come into play here, whether we're patients, family, or providers. Without a sense of safety, it's very difficult for many people to even mention sex at all, let alone to ask questions or to share experiences that are close to their hearts. Um, so we're going to go over some strategies for creating safe conversations about sexual health a little later on. Another important element of safety is potentially the effect of past traumas on present experiences. So many people have experienced sexual violence or sexual trauma in their past, and there are parts of the experience of illness that can trigger those feelings again. So things like dealing with those physical changes and feeling a loss of control over one's body. So yeah, so these are some elements of the whole when we talk about sexual health. Ultimately, the real value of sexual health and sexual expression in palliative care is in its capacity to connect us with what we care about in life, even in the context of hardship. This is a great quote from Christian Gidlin's autobiography of his experience with cancer. Nowadays, there are only a few moments when I do not think about death, when I'm not besieged by what is coming. When I make love is one of these moments. Then everything else ceases to exist. Then we disappear in a bundle of bodies.
Catherine, could I just pop in here for a sec?
Of course, yeah.
Yeah, following up, I guess it's kind of related to the quote, but somebody has shared in the chat box that after 25 years of looking people who are receiving palliative care, she says, I think sex is the furthest thing from their minds. She's not understanding any attachment of sex to palliative care. I just thought maybe you'd want to address that.
I hope this presentation will help with that. I have a couple of videos. There's one video especially that I think is going to be helpful with that idea. So if you don't mind, like just hold on to that thought. If we have more kind of issues around that later on, I'm happy to talk about it. Definitely like, sexual health, sexuality is a pretty niche topic. So that niche is where we're going to be this evening. So we'll see. Some of this stuff isn't gonna apply to every person or every patient. I think my hope is that, when the person comes along that it does apply to, that these things are going to come in handy.
Wonderful. Thank you, Catherine.
Thank you. All right. So on that note, this is a poem by the writer Chen Chen. It's from his book, Your Emergency Contact Has Experienced an Emergency. The question he poses is, how will you or how have you prepared for your death? We see his answer here. So from the perspective of providers in palliative care, like the list of things we do to quote unquote prepare for patients and clients' deaths really has a completely different focus. A lot of the time, we're often, organizing paperwork, updating code status, doing home care referrals, bedside assessments, making sure there's a personal directive, power of attorney, contact information for next of kin. We can't take away those responsibilities and those tasks from our patients and their loved ones, but our role is to ease those parts of the process. Hopefully, the more we're able to do and the more support we can provide, the more they can focus on the time that they have together. I think about this poem a lot. I really appreciate the way it kind of shifts my attention from the checklist approach that I have to work, and back to the experience of love and relationships that brings meaning to my daily life. Um, so, some of you may be familiar with the educators, sex educators, the pleasure mechanics. If you're not, I will be talking about them again later on, so I get a little bit more information. This quote, "Feelings deeply felt and shared," is their summary of feminist scholar Audre Lorde's definition of the erotic. So when I'm thinking about the role and the potential for sexuality as a part of the end of life, um, this phrase of feelings deeply felt and shared is so much more meaningful to me, than, for example, just thinking of sexuality as being limited to penile vaginal intercourse. Everyone is influenced in the way that we think about sex by the messages that surround us, whether that's from society at large, from our sex education or our lack thereof, from our families, from social media, the list goes on. So we might think of sex as being touch that's shared between two partners, that focuses on sexual intercourse with the goal of orgasm, and that takes place in the context of a monogamous relationship. But if we embrace a broader view of sexuality in the interest of cultivating more pleasure, more joy, more access to our sexual selves, that might include other forms of unpartnered touch, like masturbation, sensual and sensory pleasures, like eating delicious food or spending time in nature, even different relationship structures like non-monogamy, dating, and casual sex. So all of these are valid paths to connecting with sexuality and fostering sexual wellness. They can be adapted or reimagined according to the needs of the person, or the relationship or relationships in question. Taking a more expansive approach to the idea of sexuality and intimacy, excuse me, can really benefit people, in general, but here we're talking about people who are in palliative care. Um, and for those people, their customary forms of sex and intimacy might be inaccessible. So whether that's temporarily or potentially for the long term. This does not mean that there needs to be, a massive overhaul of a person's approach to sex and connection or a couple's approach to sex and connection, but just that there is often the potential to kind of rethink sexuality and intimacy in a way that might make those connections easier, and bring them more into reach. So I've listed here some ideas of activities or other forms of touch that could help promote intimacy with partners or with oneself. So I'll just read that list here. It's co-sleeping, massage, hand holding, kissing, dancing, oral sex, reading aloud, sharing memories, porn or smut, bathing, deep conversation, taking workshops, so on and so on. I really love these non-intercourse ideas for connection and intimacy, especially in the context of illness and end of life. Because in those moments, it's the time-limited nature of relationships becomes so clear. Incorporating sexuality, love, and expressions of intimacy into the daily or weekly routine when someone's experiencing illness or when caring for someone at the end of their life. This can be a way of honoring those moments that really matter. If anyone has any other ideas or any questions or anything, feel free to put that in the chat. If there's been any other comments, this is a great time. Or I can carry on.
Yeah, there was one comment, just
Sure.
somebody else who was a little bit earlier on, Catherine, before you sort of went
Mhm.
through the list, just mentioning that it's not always about sex, but sexuality.
Sorry, can you repeat that?
That it's not always about sex, I guess the act of sex, but
Totally.
sexuality. So
Yeah,
you've touched on.
exactly. Love that. So yeah, I think that's one of the spots where people get stuck, like talking about sex and sexuality in the context of other health issues. Yeah, like there's more to it. So I hope that this will illuminate a little bit of that or start a conversation on that.
Excellent. Yeah, there's nothing else for now, Catherine.
Okay, sounds good. So I'm just going to take a minute here and just talk about queerness in palliative care. So queer folks as a whole face disparities in their access to healthcare and in their health outcomes as compared to the general population. Many queer folks have had negative experiences, traumatic experiences with homophobia or transphobia from healthcare providers in the past, which can reduce the likelihood that they're going to reach out to the healthcare system for support later on. All that means that they have more barriers to accessing specialized care like palliative care, and that can unfortunately result in decreased symptom control at end of life. I used to have here a clip from a video from a Calgary organization called the Rainbow Elders, which is a support group for 2S LGBTQ plus seniors. Unfortunately, they just took down the video like a couple of weeks ago, so I don't have that to show you anymore. What I really liked about that video and what I wanted to share was that it highlights kind of the amount of energy and investment that it can take for queer people to be true to themselves and to express their authentic selves as they age and interact with the healthcare system. So for example, like we use the expression coming out, and that's often framed as a single event, when in reality, for most people, it's experienced as an ongoing process. So queer folks need to continuously come out in different areas of their lives. So whether that's with friends and family, at work, to neighbors, community members, and then of course to their healthcare providers and their healthcare team. So being out in all areas of life can provide a sense of integrity, as well as the ability to kind of relax into yourself, knowing that while not everyone may like it or support you, you can be who you are. For our elders, for other folks who are living with illness, it may be a concern that they will not always have the energy that's required to be out and proud in a system where transphobia, homophobia, colonialism are all very much present. It's especially important when you're working with the queer community to honor the importance of chosen family and community support. In nursing school, I was always taught, and I'm sure many of you were taught, the family is who the patient says they are. This is such a great opportunity to really incorporate that into patient care. Queer people, of course, are more likely to have strained relationships, complicated histories with their families than, the average person off the street. So just make sure to be mindful of that. For example, when you're sharing sharing patient information with family members who call for updates or allowing visitors, it's really wise to review this with patients early on so that you can anticipate any needs that might come up related to biological versus chosen family. By the same token, we do need to be respectful when patients may not want to share with us or with the healthcare team about their relationships. So sometimes, there may be a visitor who comes to see them every day who's identified as their roommate. If that's the case, then fantastic. Like that's their roommate, even if it seems like there might be more to the relationship than that. If you are interested in learning more about queer health and palliative care, there actually was a presentation from this Thursday evening series last year. So I would really recommend checking that out. It was, let me see this. The name of the presenter was David Kenneth Wright.
I put it in the chat, Catherine.
Sorry?
I put it in the chat. We
Oh,
were
fantastic.
like
Thank you so
reading
much.
each other's minds.
Yeah, it's perfect. Yeah, so that's queer inclusive palliative care. So if anyone's interested in checking that out, it was a really good watch. It's also linked on the Thursday evening series page.
Catherine, the chat box is really active right now.
Oh,
We-
okay. I'll
but,
head back here. All right.
Yeah, so I think in relation to the slide before this one, there were a few
Okay.
ideas that were coming up. So someone has shared in terms of other thoughts, listening to favorite music.
Yeah, absolutely.
Then some other comments around people enjoy hand holding, cool cloth on a brow, cuddling, being held, creaming feet, hands, and arms.
Yes. Yeah.
Touch being very important to feel connected. Let me,
Yeah.
yeah, someone mentioned that all of these things can help anxiety.
Totally. Yeah, that's wonderful. Yeah, I love all of those examples, and I think it's so important to just kind of remember that these things can kind of connect you with other parts of yourself. Like it doesn't always have to be something that we would think of as like explicitly sexual, but it all contributes to just the overall sense of wellness. So yeah, thank you for all those ideas.
Yeah, there's still a few more, so
Yeah.
if you're okay, we still have
Yeah,
time.
of
Okay.
course, yeah.
Yeah, somebody mentioned just maybe a focus also being on children and how how it will be for the children once an individual is gone.
Yeah.
Privacy and intimate moments are quite often robbed due to medical interventions and the
Mhm.
general flow of various care professionals. Carving out loving acts and savoring them is important.
Yeah, we're going to talk about that too. I think that's a really big point.
Excellent. And here someone has shared a perfect example was a young couple. The husband was towards the end of his life, but he would enjoy and would give great pleasure seeing his wife receiving a massage from a massage therapist in his room.
That's so nice.
Yeah.
Yeah, like I think there's lots of opportunities with that, where we can adapt. Maybe in the past, like they enjoyed getting massages together, giving each other massages, that kind of thing might not be accessible in that form right now. But you can adapt to something that still gives you that sense of intimacy.
Yeah, and then just a final comment that's just come in. So sometimes even before people come to the end of life and sexual function is impacted, couples develop alternate means of sexual satisfaction.
Yeah, absolutely. Okay. I'll just skip ahead here. I have a little video. So this is a video that's just under 4 minutes. And it's about this person's experiences with sexual side effects as a result of cancer treatment. So let me see if I can get this going.
I had no idea when I had my ovaries removed through a full hysterectomy at age 44 because my left one had stage 1 ovarian cancer growing inside it. How important they were to my identity as a sexual lesbian. Up until then, my ovaries were just there until they were gone. I quickly learned my sexual being was dependent on what they secreted. Estrogen gave my vagina its vitality, and the small amount of testosterone that was released by them gave me my sex drive, my arousal. Without their presence, I no longer knew my body and what it was capable of. Who was I? I knew I wasn't sexual. I had no drive. Thankfully, I was not in a relationship while exploring my new identity. My body was changing drastically. I was suddenly in full-blown menopause. It was like I had jumped off a cliff. There was not going to be a slow ease over many years. I was full of fear. Would I ever be able to have a fulfilling, well-rounded relationship again? I was overwhelmed with fear at the thought of getting naked with another woman. I had no sense of myself sexually anymore. I had envisioned my future including a well-balanced, mutually supportive, satisfying relationship, one that included a healthy sex life. At no point during my diagnosis or treatment was having a future sex life ever discussed with my caregivers. I didn't even know to ask. I guess we were all focused on making sure I stayed alive. Looking back, I'm angry that this was never mentioned. Was it because I was a lesbian and it wasn't deemed important by my male doctors? I want to believe it was just overlooked. Yet there is a part of me that thinks that if I had had a man by my side, my sex drive would have been brought up earlier in my treatment. During this time, I belonged to a lesbian support group and was comforted by their stories. Most of the women were older, and no one in the group had had a full hysterectomy, so shared reality was not there for me. One day, another woman and her partner came into the group. She was a couple of years younger and had had the same cancer and surgery. Through her, I learned that there was hope for a satisfying sex life post-loss of one's ovaries. I was now hopeful. Off to the sex doctor. Her words, not mine. I went and learned that my hormone levels at the present time were pretty non-existent. It was good to learn that what I was feeling was from a physical change in my body and not something in my head. This gave me peace of mind. Now I had a plan. She put me on a topical testosterone for arousal. I was also given localized vaginal estrogen to give my vagina a new lease on life. I will always be thankful that there was a support group available for me to go to that was for lesbians and bisexual women. I am grateful that I had the chance meeting with that lovely woman. Jump ahead 12 years. I am happy the fear is long gone. I have found that supportive, loving, sweet, beautiful woman to share my life with.
Okay. In that video, I think it's really interesting the way the narrator says, thankfully, I was not in a relationship while exploring my new identity. To me, that really highlights how much stress can be associated with the experience of sexual changes during serious illness. The implication in that statement is that, the sexual changes brought on by a cancer treatment were so significant that they could have been a threat to an existing relationship. I would really love to hear any comments after hearing this woman's story, if there was anything that stood out to you the most in the video, or if you noticed anything that surprised you, that really resonated with you.
Yeah,
So
a couple of comments there already,
Yeah.
Catherine. Somebody shared that in the case of her brother who had an accident and broke his spine, when he was unable to have sex with his wife, they ended up divorcing.
Mm,
Yeah, and
that's
somebody
really
else, it was
tough.
a lovely story.
Yeah.
Um, yeah, the highlighting that the fact that physicians never ask about this.
Mhm. Yeah, that's actually the next thing that I want to explore. Just while this person is expressing, how important sexual health and sexual function are to her as part of her cancer experience, she also says, at no point during my diagnosis or treatment was having a future sex life ever discussed with my caregivers. I didn't even know how to ask. So let's kind of take this opportunity. We can discuss some strategies for approaching these sexual health conversations, just so they're not overlooked in the future.
Great.
So when you review the literature that exists about sexual health and palliative care, there's a consensus that you'll find on a few things. One of them is that patients are largely not asked about their sexual health by their healthcare providers. And the other is that providers say the main reasons they don't ask are because they're uncomfortable, because they don't feel prepared, and because they don't know what to say. So my hope is that these strategies will make talking about sexual health a little bit easier on both sides of that conversation. The first tip I have is to think about language. So for some people, talking straightforwardly about sex is a skill that they've practiced. Many people are not comfortable talking about their sexual health directly. So some people may find it harder to talk to healthcare providers because they feel like strangers. Others might find that, feeling like strangers actually helps them to talk about sexual health. So it really varies from person to person. My recommendation when you're starting out is to try mirroring. So try to use the language that your conversational partner is using. This comes up for me a lot in my work at the STI clinic. Excuse my language here, but I'll give a couple of examples. So clients may say things like, piss test, rimming, those kinds of things. If I respond to them using really clinical language, like a urine specimen or like analingus, I kind of risk our rapport and potentially their understanding of the information that I'm trying to share. So the goal is to have clear communication and understand each other. So when we try to overcorrect into more formal language or into something that's considered, clinically accurate, we might miss the opportunity to really hear what the other person is telling us. So it's a bit of a balancing act. While you don't want to be unprofessional by repeating some of the more crude slang terms that people sometimes bring up, there's usually a middle ground where you can use softer language that's still relatable to the client without it becoming completely kind of sterile and clinical. There is, of course, a flip side to this dynamic, and that comes up when the use of more comfortable euphemisms actually makes the conversation more muddy. So an example that I've seen used as a way for providers to talk about sex with clients is to use the word intimacy instead of actually saying sex, sexuality, or sexual health. Um, Honestly, like this will be a judgment call. Using the word intimacy can be a really great way to test the waters if you're bringing up sexual health for the first time. It can definitely make room for those more expansive views of sexuality that we talked about a little bit earlier. But at the same time, it can also be vague. So it can be unclear. You just want to be cautious and pay attention kind of to how your conversational partner is responding to that type of language. Another obstacle that people run into when wanting to discuss sexual health in a palliative care setting is just knowing how or when to bring it up. I truly recommend getting this out of the way as early on as possible, so that even if you feel like there aren't any pressing needs or any relevant information to share at that moment, you can identify yourself as someone who's safe to talk to if the conversation does arise in the future. I would really love to see sexual health being addressed on client intakes or in initial interviews. Um, I always remember when we, were training and we learned about patient admission checklists, like there was always a question about sexual health listed. The one I remember encountering was quite broad. So it was something like, do you have any questions or concerns about your sexual health related to this admission? But the thing was, in practice, most nurses didn't ask it. So I am here to say, ask. If there's one thing you take away from this presentation, that's what I would really want it to be, is just ask, and be there to open the conversation. So even if there's no immediate questions, just hearing somebody talk about sexual health can be really validating, and it lets people know that their concerns are important, and that they're going to be taken seriously. There is a model called the Plissit model, so that's Plissit, and that can be really helpful for providers when you're structuring conversations about sexual health and providing appropriate interventions kind of without overstepping. So what that stands for is permission, limited information, specific suggestions, and intensive therapy. Permission can take the form of the intake checklist question, like I just mentioned, or it can be more direct. So you could say something, for example, like, some patients have appreciated getting information about how to care for their sexual health while they're in treatment. Is it okay if I share some information with you about that? limited information, that means that the provider should identify what it is that that patient is interested in and provide information relating specifically to that. There is so much information about sexual health available online. It can be really overwhelming, and it's hard to know where to look. So it's really helpful to have that, excuse me, kind of curated by a trusted professional, at least as a starting point. And then as we get into the other steps of the implicit model, so specific suggestions, like those would be actionable recommendations from the provider for the patient to improve in their area of concern. And then that final step of intensive therapy involves referring patients onwards to specialists. If I were working my role as a palliative care nurse, for example, I would not be in a position to provide those specific suggestions or intensive therapy. But I could recommend referrals to other providers who would be able to complete those steps with the patient. All right, and that ties into setting expectations. So if I were talking to a patient and they started opening up about sexual health concerns, I would want to provide some positive feedback for what they've shared, and then also be honest about my ability to support them directly. So it might look like saying, I'm so glad you mentioned that. I know that's something that comes up for folks, who have chronic pain or who are in this stage of their treatment, etc. I'm not an expert with this, but I've heard great things about this resource, this person, this organization. If you want, I can start that referral for you or provide you with their contact information. So that way, patients know that they've been heard, that they have some options for moving forward, and that you are a trustworthy provider who knows their own limits. So I think that's really important to set out. Another important element of talking about sexual health is asking for what we need. This was kind of alluded to in one of those comments that we heard from the chat. Like in inpatient settings, an example of a request from a family or a patient might be for privacy. So providers should make an effort to be accommodating of that type of request, and also just communicate clearly about any expected limitations. So for example, like I could say to a patient, I'll pull your curtain and I'll close the door. I'll let the team know not to come in until after lunch, but I do have to come in later to hang your next IV medication. So I'll knock and come in at around 1 o'clock. So this way everyone kind of knows where the possibilities are and also what those limitations are. And you've set clear expectations, you can kind of negotiate around that within the limitations of the setting that you might be in. Another way of facilitating sexual health conversations is to provide other avenues for conversation outside of the healthcare environment. So like we've been saying, like some people might not be comfortable talking to their healthcare team, or they just might find that their issues aren't applicable to the expertise of the people on their team. Peer support is such a great option. It removes that provider-patient hierarchy, and it allows people to share their lived experience. There's also the option of heading online to, discussion forums, blogs. There's a certain amount of safety in that anonymity, as well as just being in the company of other people who might have the same questions. There's so many resources available now over Zoom and through online meetings. It really opens up a lot of possibilities for folks who, maybe live in areas that don't have the resources they're looking for locally. And then as we just heard in that previous video, peer support can be a really great way for people to make connections with others who have had similar experiences, and that can make all the difference like it did for that person. I do have another little video, a short video about kind of these concepts in the sexual health conversation. Is there anything in the chat that we want to touch on first, or shall I move on to the video?
I'll just summarize quickly. There are a
Sure.
few comments. One was just a mention that how it's uncomfortable, how Val remembers being
Yeah, of
uncomfortable as a
course.
student nurse. And, for
Yeah.
many of us, having these conversations until you get comfortable, it's uncomfortable.
Mhm.
Another comment, someone as an icebreaker using humor, joking around.
Definitely.
Yeah, and then somebody sharing that they feel very lucky to work in an environment that's accepting of people and different sexuality and how much
Yeah.
how they go out of their way to make sure that they're non-judgmental.
Yeah, that's really nice to hear. Yeah, and I'm sure it's appreciated by the clients and families as well.
Yeah.
Okay, and let me pop on this video. So yeah, so this is another kind of 4-minute video. This one is from an American organization, so that's called Living Beyond Breast Cancer. Sorry, my little cat has joined us, if you can hear him in the background. This video is on the topic of talking about sexual side effects of cancer treatment. Let me get that one going.
So almost immediately, even though I hadn't yet started chemo, but I knew that I wasn't going to be able to have a really good physical relationship with my husband for however long I was in treatment. When we tried to have intercourse, it was extremely painful and it hurt in so much. It was like something I'd never thought that I would ever experience. And from that moment, and it was the first month that I'd been diagnosed, I realized that something was massively wrong and nobody wanted to talk to me about it unless it had to do with my fertility.
There were no explicit discussions with my healthcare provider about how to prepare and cope with the side effects that would come along with my treatment as it related to my sexual health and intimacy.
I was a young, single woman. One of the first thoughts that I had when I started treatment, I was like, how am I supposed to date? How am I supposed to be sexually active? When it hit me, it was really confusing and concerning because it was such severe symptoms. And yes, I was going through treatment, I wasn't totally surprised, but some sort of warning would have been nice.
I didn't realize till I went to the doctor, and I was my doctor's first really, really young patient. So I kind of struck a chord on him. He treats me like really specially, and he's always like informing me. And he has like a really open relationship with me, and I think that is like bittersweet, because it's kind of like a privilege that not a lot of women have. He was the one that that realized that I had dryness, and then he started asking me all these questions like, how is your sexual life? Does intercourse hurt? Like, how are you're feeling with like your sexual desire and stuff like that? And that's when I realized that there was something wrong and it wasn't just me.
It took me about a year before I realized that it wasn't just me, that there are women everywhere that are suffering with sexual side effects of their breast cancer medications, and nobody has talked to them about it. And I think it's a main thing where it's a side effect that doctors aren't comfortable talking about, or they don't think to talk about because they're too busy saving the person's life. And while I understand that, there's also a quality of life that needs to be brought into account.
I think the misconception is that, they're not thinking about this because they got to think about cancer part of it. And, I wasn't so concerned about the cancer treatment part of it because I feel like it's a treatment plan. There is a plan. And so we're just going to try it out and go from there. And if they would have initiated the conversation earlier, I probably could have been doing a lot of the preventative therapies. Maybe my tissue wouldn't have dried out so fast. I don't think it hurts to bring it up. You could just be like, hey, this side effects is going to affect your sexual health. Do you have any concerns about that? I have resources. If you're not ready to talk about it now, it's okay. But when you're ready, I'm here. I got you. And that's it. And just leave it at that. That way we are aware, and it puts that seed in our brain to kind of, oh, okay, now I know I could, do something about it instead of just suffer through it.
I wish that my provider had brought up what was to come in terms of my sexual side effects so that we could have then come up with a plan. And if they weren't the expert to deal with that, refer me to someone that is. But waiting for the patient to discover what's going to happen to their body leads to these feelings of shame and guilt, versus if I know this is an understandable side effect that's going to come and here are the resources should this happen to you, I would feel much more prepared and empowered for how to take on this aspect of my treatment and my long-term side effects. So I would beg providers to have these sometimes awkward and difficult conversations with their patients about sexual side effects and how to focus on their intimacy and sexuality while navigating breast cancer.
Okay. Yeah, I really appreciate that video. I really like the way all those young women talk about their experiences. You might have noticed some of the different ways that each of them spoke about their experience, the different language that they used, while all talking about the same type of experience. A couple of them acknowledged exactly that was mentioned in the chat as well. Just how awkward, sorry, my cat is attacking my foot here. But yeah, just acknowledging how awkward or uncomfortable it is to bring up sexual health with a patient. But how it really can benefit them by allowing them to prepare for changes that they may eventually experience, as well as just letting them know that it's okay to ask about sexual health or to address it with their providers. Sorry, just watching out for my little guy here. Was there anything in the chat that anybody wanted to touch on?
Yeah, I could share there's something there, Catherine, where a participant shared that in some cultures, like where they are today in Zambia, where when someone is critically sick, a caregiver at the bedside has to be the same sex if they are not married. So yeah, just bringing the cultural aspect to recognize.
Totally.
Yeah.
Yeah, and that's always going to be another dimension of all these conversations as well, right? As people's cultural backgrounds, the kind of cross-cultural communication that might be happening between them and their providers.
Yeah, and then a further comment around the idea that doctors usually focus on treatment side, not necessarily the psychosocial side of care, where social workers may be providing support.
Totally. Yeah.
Yeah, that's all that's there right now, Catherine.
Perfect. Thank you. Okay. So in the interest of kind of working on these skills, becoming providers who are able to support clients with their sexual health, I wanted to share this list of reflective questions for healthcare providers. It's from an article. I have the whole title here on the side. Practitioner's Guide to End-of-Life Intimacy, Suggestions for Conceptualization and Intervention in Palliative Care. I'm confident there's lots of us here who are familiar with this type of self-assessment exercise. I'm going to read a few of the questions that I especially like. If you want, you can take a screenshot of this, or you can search out the whole article on your own if you're interested. I really like these following ones. Number 6, what are my initial reactions when thinking of working with an older sexually active couple during the dying process? Does this reaction vary when the couple is a queer couple or a heterosexual couple, married or unmarried? Number 9, what stressors might I face in supporting client intimacy at the end of life? Number 13, am I worried about advocating for end-of-life sexuality and how it might be perceived by the family members, my colleagues, or my work administrators? And 15, who or what are my resources for promoting end-of-life intimacy for my clients? So I think working through some questions like these can be really helpful in identifying your strengths and weaknesses in sexual health. as well as just highlighting where it would be helpful to seek education or resources for yourself, your clients, and your workplace. For myself, one topic that I can find really difficult to talk about is sexual function as it relates to the penis and the prostate. So I feel like I don't always have a solid understanding of the issues or side effects that might arise during treatments. I'm not as familiar with resources that are available for people with penises as opposed to people with vaginas. But like we just saw in that video, it's still really important to address the reality of side effects and the possible sexual health consequences. So this is a situation, if that came up with a patient of mine where I could use my skills in setting expectations, to share honestly with a patient and tell them, for example, that I know many people experience sexual side effects with their condition or their treatment, that I'm going to reach out to my team for more information and support, and that I'm available to discuss any concerns so that I can learn more and I can bring that knowledge back. We don't have to be providers who know everything like as soon as we're asked. Like it's okay to just be honest and be vulnerable with your clients and say, I want to help you with this. I'm gonna have to go and get that information and bring it back to you at a later date. Okay. So I've just shared some resources here, for anyone who likes podcasts, which I really do. These are some episodes from a few different podcasts that I've enjoyed. So we were speaking a little bit earlier. I shared a bit from the pleasure mechanics. So this first one, on the left is their podcast, just Speaking of Sex with the Pleasure Mechanics. This is one of my favorite podcasts. The pleasure mechanics are a queer couple. They have been sex educators together and separately for decades. I really love their kindness and their enthusiasm for all kinds of sexual health conversations. These podcast episodes are usually quite short, so they're about 30 minutes, and they have a huge variety of subjects. So if there's anything you're particularly interested in talking about or learning about, you can often find it, just with a search through their archives. I think this podcast is a really great tool for starting conversations with partners or loved ones. So I would really recommend, try listening to a podcast together. It might give you a way into some of those kind of more tender, more difficult conversations that we've been discussing. This episode that I've listed on here, it's a bit unusual. It only features one of the two. So one of the pleasure mechanics is being interviewed for another podcast. It runs quite a bit longer than most of their episodes, so it's just over 2 hours. It's one that took me a few listens to get through to the end, but I truly can't recommend it highly enough. The episode is called Turning Towards Pleasure While Living with Pain and Illness. The conversation highlights a lot of the themes that I've been touching on this evening. Honestly, there are times when I prepare for these presentations that I think I should just be playing like an hour-long clip of this episode. So if this is a topic that you're interested in, definitely give it a listen. I think it's super valuable. The middle one here, some of you might have heard of this. This is a podcast called Dying for Sex. It's about Molly. She's a woman in her mid-40s. She has stage 4 breast cancer, and she embarks on what she calls a sexual odyssey. The podcast is hosted by her friend Nikki. So Nikki's supportive, but doesn't always understand Molly's choices. The episode that I've listed here is one that discusses a hookup that Molly had while with a date. He visited her while she was in hospital. And this is kind of, yeah, they just go over what happened with that and how everybody reacted to it. I really love this episode. I think the story of the hookup is really lovely and really sweet. And I appreciate the dimension that Nikki brings to the conversation, as, the best friend. She doesn't always understand the role of sex and sexuality, especially in this context, like when Molly's in the middle of an inpatient stay in hospital, right? She expresses feeling really protective of Molly. She feels suspicious of the intentions of her date. And they kind of just get to explore that together. I will warn you, this episode includes discussion of childhood sexual abuse starting at the 30-minute mark. So that's just something to be conscious of if you do decide to listen. Make sure that you are taking care of yourself and that you're conscious of that if that's not something you want to hear about. The other thing is I believe this is now subscription only from Wondery. So you can get a free trial if you want to listen to it, but otherwise it's a paid subscription. This last one here is an episode from the podcast Disability After Dark. So this features an interview with disability activist and sex educator Eva Sweeney. Eva's pronouns are they, them. Eva and the podcast host, who's Andrew Gurza, they're both disabled, and Eva is nonverbal, so they work with an aide who helps them to communicate. Disability After Dark as a podcast is one that just really demystifies sex and sexuality for people with disabilities. This conversation with Eva is no exception to that. I really find their interview particularly compelling because there's a section where they discuss how to find personal care workers who are comfortable providing care that's related to sexual health, how to talk about sex with your care team. They give a great example of setting expectations, where Eva talks about, spending a night with a partner and informing their care workers ahead of time that Eva was going to be naked in the morning when the caregivers come in to help them get ready for the day. So I think, yeah, that's an excellent use of just those skills in communication and expectations. Eva has a website that's called Cripping Up Sex. They offer online workshops and classes. There's one that's called How to Talk to Your Doctor About Your Sexual Health. And there's another one that's called Chronic Pain and Sex. So just some places to get started there if you're interested in podcasts. This is a bit of a different departure from that topic. If anyone, was there any comments or anything that I should address before we carry on?
Just a couple of quick things. So yeah, another comment around primary care physicians can be helpful with discussions, but are sometimes uncertain about what options are available, reach sexual health, for example, hormones. Yeah. Someone appreciated your language around solid understanding when discussing penises.
Thank you.
And the podcast is available for free on Amazon Prime Music, one they said was potentially.
Oh, okay, great. Thank you for sharing that. That's good to know. Okay,
Yeah,
perfect.
that's it, Catherine.
Okay. So yeah, we'll move on to this topic of consent. This subject came up as a question actually in a previous version of this presentation, so I just wanted to spend a bit of time on it today. It's actually quite a rich subject, and one that I can't fully address just with all the legal implications around consent in healthcare, but we'll kind of get into that a little. So the main context for concerns about consent in palliative care is when a patient or a client demonstrates cognitive changes. And there's a question as to whether they have capacity to provide consent for sexual activity. Sexual consent cannot be governed by a substitute decision maker. So it requires an ongoing assessment of individuals' capacity and understanding. This is where a lack of education on the part of providers and or family members really has a significant impact on the well-being of patients, because even like quote unquote appropriate or consensual sexual expression might be met with disapproval, disgust, possibly panic from others who believe that sexual health is not a part of older adulthood or end of life or illness, those kinds of things. So I'm just drawing from an article here called Sexual Consent Capacity, Ethical Issues and Challenges in Long-Term Care, which is by Jennifer Hillman. These are the three main constructs to examine when assessing an individual's capacity for sexual consent, which are knowledge, reasoning, and voluntariness. We'll start with knowledge here. So the patient or the client in question should be able to demonstrate an understanding of consent. So they should know how a person might say or show that they're providing or withdrawing consent. They should understand that sexual activity or sexual contact that proceeds without consent is harmful and unethical. We talk about risks that can be associated with sexual activity that can come in several forms. As always, there's potential health risks like STIs that are involved in sexual contact. And in the context of assisted living facilities or an inpatient setting, there's also kind of a social risk of gossip amongst other residents or patients, or amongst staff even. Depending on a person's relationship with their family members, and those family members' values around sex and sexual expression, they might also face judgment from their loved ones. And then, yeah, as far as knowledge is concerned, it's really important that a person be clear on who it is that they're engaging in sexual activity with. So if we're talking about someone, who might be prone to forgetting who people are, or for example, mistaking someone for a past partner or for a deceased spouse, that can quickly complicate their ability to give informed consent. When we talk about reasoning, we want to know more about a person's decision-making process. So although someone might make a decision about engaging in sexual activity that a caregiver or a family member might not agree with, it's important to make the distinction between a third party's disapproval and an actual departure from the individual's own historical values and beliefs. And then it's also important to take into account physiological influences on thought process. So things like medication, disease process, dementia, brain injury, etc. Some of those factors can be mediated with changes to the care plan, while others might not be easily managed. Finally, we have voluntariness. So that just means that the choice to participate in sexual behavior or sexual expression is made freely without coercion. The individual should be able to abstain from unwanted activity. Because with all of these three factors, there's so much room for change in each of those categories. Those capacity assessments do need to be ongoing and kept up to date. If this is something that you want to learn more about, or maybe it's relevant to your practice area, I would recommend having a look at the Hillman article. I have the reference at the end of the slides if you didn't write down the name or anything, but yeah, there's a lot in this, and a lot of kind of legal elements that unfortunately I'm not qualified to get into, but hopefully this is a bit of a beginning. And of course, yeah, the article does state a lack of staff training should not prevent a resident or patient from appropriately expressing their sexuality. Okay, so these are some examples of practical interventions. A lot of them can be readily offered to patients and families according to their needs. If you know of any other helpful interventions, and I know a couple of people have mentioned some things that would fit in here already, please go ahead and share those in the chat. Medications are an intervention that's likely to come up first in a clinical environment. HRT, or hormone replacement therapy, can help with issues like decreased libido, vaginal lubrication, Some cancers, of course, are hormone responsive, so this would not be an option in those cases, but it's something that can be brought up and discussed with the care team. And then, of course, we have pain management. This is usually already a top priority in palliative care. It's a relatively simple intervention. I know that's understating it in a lot of cases, but it can go a long way in improving sexual health and quality of life as a whole. So I have next logistics and scheduling. What that can mean is just planning ahead. So whether it's for visits or special occasions with the patient and their loved ones, if the patient has attachments that they would like removed to facilitate intimacy or sexual activity, we can do our best to make arrangements for that. So something that comes up for a lot of folks, for example, is if they have a urinary catheter. Is that something that could potentially be removed prior to a visit? Could they maybe transition to in and out catheterization? What else can we adjust there? Potentially IV medication and hydration could be coordinated to make visits easier. Sometimes the answer to these questions is going to be no. It is definitely worth asking and checking out some possible options. For room layout, we can arrange to provide more privacy, more closeness with the physical layout of the rooms. Yeah, I know I've always loved to see when couples are admitted to hospital together and they have their beds pushed together so that they can be close and have that physical contact throughout their stay. Many facilities also have the option of bringing in reclining chairs or even cots for visitors, which can allow people to stay comfortably throughout the day and night. Even, the hospice where I volunteer here in Calgary has just installed Murphy beds in their patient rooms so that those overnight stays with loved ones are going to be easier going forward. As far as the interdisciplinary team, there's tons of potential interventions available. We have occupational therapy and pelvic floor physio that can both provide support for people whose sexual health might be affected or suffering due to their illness. With OT, that might look like recommendations for modifying activity, potentially sexual activity, or providing assistive equipment or technologies that could make sex easier or less fatiguing. Pelvic floor physio can help manage pain, incontinence, lymphedema, and more. Mental health supports, some referrals hopefully are part of the palliative care assessments already. Social work and spiritual care are great resources for this. Definitely make sure to take advantage if those are part of the care team. What's next here? Toys. Toys or assistive devices are another intervention that might be suggested by OT and pelvic floor physio. There's a lot to explore independently. Like I was talking about in the podcast slide, the website or the Instagram Cripping Up Sex that Eva Sweeney works on. They have tons of reviews of sex toys that address accessibility features. So those can be really helpful for folks with pain or limits in their mobility. And last one I have on here, safer sex is a really important consideration in palliative care. Many people undergoing treatments like chemo or immunotherapy, it may create a situation where sexual contact is actually unsafe for their partners. So for people who are wanting to be sexually active with a partner or partners, they need to know when it's safe to do so. Can they have sex during treatment? Do they need to wait a certain amount of time? Condoms and dental dams are a really good starting place. But it's important to find out when abstinence is the safest option. And that really needs to be clearly communicated to patients and their loved ones.
Catherine, there was just one comment in the, oh, no, there's a couple.
Sure.
Recreational therapists. So Ashley shared recreational therapists could also play a role helping with leisure education, hand massages, aromatherapy, and helping to source items that people may need to express their sexuality on a recreational or leisure basis.
Yeah, fantastic. Yeah, I think once you kind of start digging into it, like once you're brainstorming about like, okay, who can contribute to this conversation, it's really like everyone has a role, you know, like there's nobody in the care team who I would really say like, oh, that practice area doesn't have anything to do with this. It's just a matter of like the conversation has often not come up and it's not necessarily included in a lot of people's training. So you might think like, oh, like what does spiritual care have to do with sexual health, you know? But once you kind of dig into it, there's so many possibilities. So yeah, I really appreciate that.
Yeah, for sure. And one other comment, not just to remember that there's also the sexuality of the family caregiver too, for the other person.
Absolutely. Yeah. Yeah. That's huge. Okay. So we had talked about this, Val and I had talked about this before my presentation. This video is 11 minutes long. So I just kind of wanted to feel out how everyone's doing. I'm really coming to the end of my content. So if everyone is feeling up for it, like we can watch this video. If you're not feeling 11 minutes of, of a video, then that's also fine. It's a really good one where she kind of talks about physiological side effects of cancer treatment. So if that's kind of your area, you might want to pull it up on your own. Does anybody have a strong yay or nay feeling on this?
We have one okay with me in the chat box.
Okay.
We're doing well for time.
Oh.
We've got still like 41 minutes, Catherine. So
Oh, fantastic. Okay,
Yeah.
well, why don't we dive in then? Unless everyone suddenly says no in the chat. But yeah, I
No,
think this video is a good summary.
we're getting thumbs up, so.
Okay, awesome. All right, I will get this going. Oh, if I can. There we go.
I'm not hearing anything, Catherine. Are you?
I am. Let
Uh-oh.
me see.
Isn't that weird that we could hear the others, but not this one?
I can always play it on my browser.
Sexual health cancer, and to say for
We're good. Maybe it was just
thrilled to be here.
Sorry, I'll try and get to the beginning of her speaking. It was just music up until now.
I'm thrilled to be here to chat with you all today about sexual health and cancer, and to say for sure that yes, it is important to talk about, and we'll discuss why that is today. First, a couple of notes that sexual health and well-being is an important aspect of life for many, many people. This does not change with a diagnosis or treatment of cancer, of course. Cancer treatment and sexual well-being is not something that is spoken about often, given the fact that for many, treating the cancer and becoming cancer-free or in remission certainly takes precedence, understandably. That being said, it's very important for patients to be able to address sexual health concerns at whatever point in treatment they feel like that's becoming a point of concern for them. And so I want to talk a little bit today about what some of the changes in sexual health might be as we go through cancer treatment, and how we can start to talk about that with partners and with our healthcare team. First and foremost, we know that human sexuality is intrinsically a biopsychosocial process. This means that there can be multiple and simultaneous contributions to how a person experiences their sexual health concerns. For example, biological contributions might be medical diagnoses, medications that somebody is taking, certain treatments or therapies that come with cancer treatment in particular. Psychologically, self-esteem, emotions tied to sex and sexuality, beliefs about one's own body, behaviors related to sex. All of those psychological factors can absolutely impact our sexual health and relationship health. And then socioculturally, at kind of a larger level, faith traditions, cultural backgrounds, one's ability to communicate about sex with their partner in an open and healthy way, and expectations about sex and sexuality all play a really important role in one's sexual health. Sexual health concerns related to a diagnosis of cancer can arise before treatment, during treatments, and even after treatment in survivorship. These are just some of the common concerns that we see around sexual intimacy and sexual health throughout the oncology process. So this might be lowered or loss of interest in sex or lower libido, changes to how your body experiences arousal, whether that's erectile concerns or vaginal dryness or atrophy, changes in sensitivity and the ability to achieve orgasm or climax, experiences of pain with sexual stimulation or sexual behaviors, entering into surgical menopause, other changes to the body that can directly or indirectly impact how you experience sex and sexuality. So things like changes in hormones, changes in how certain body parts work, damage to nerve endings, fatigue, nausea, bowel and bladder concerns. All of these overall changes might indirectly impact sexual health as well. And then, of course, we'd be remiss if we didn't take note of the interpersonal partner dynamics, the relationship dynamics that are involved here, right? So there can be an impact on how you and your partner experience and understand your sexual lives together during cancer treatment. For many partners who are also caretakers, navigating sex amidst cancer care can be a unique, novel, and pretty stressful experience. So there might be avoidance of sexual intimacy or talking about sexual health. And this might be kind of on top of already limited sexual health education and feeling like you maybe can't talk with your care team about what's happening around sexual health during the cancer treatment. I want to take some time with you today in our limited time together to talk about some of the changes that might happen during cancer care. And I want to start with just some notes about safety, right? So during cancer treatment, during oncological care, even if you think that your fertility may have been impacted or periods have stopped with treatment, if you are still of a reproductive age, it's possible that you might still be able to become pregnant or to get someone pregnant. And so it's very important to talk with your provider about reliable birth control options and if a pregnancy is desired, when it will be safe to try and what that process might look like for you. Other safety concerns revolve around chemotherapy and cancer-fighting medications. So we know that some of these medications can appear in bodily fluids for up to 48 hours following treatments. And for some bodily fluids, such as bowel movements, even up to a week later. So we want to be very cautious and consider barrier devices and methods to protect sexual partners, particularly around chemotherapy and other cancer-fighting drugs. And last, but certainly not least, if any of the sexual activities that you are engaged in, whether or not you're also engaged in cancer treatment, if this activity becomes painful at any point, it's really important to stop. This is not a time to grit your teeth and push through the pain. This is a really important time to consult with your medical team about safe and appropriate treatment options. Sexual pain is often treatable, but we need to make sure that our care team knows that that's happening and knows that that's a concern. A couple of notes about vulvovaginal changes that might happen with cancer treatment. So vaginal dryness and changes in the vaginal structure can occur with chemotherapy, radiation, surgical procedures. And you can see here on the right-hand side how much the structure of the vagina may change and the tissues of the vagina may change if we enter into menopause because of cancer care or because of radiation or surgery. There are changes to the vaginal area or the vaginal tissues. Oftentimes these changes can lead to dryness, pain with vaginal penetration, whether that's sexual activity or a pelvic exam. These are really important changes to keep your cancer care team aware of because they're really excellent treatment options. And I listed just a few here. These are things to be aware of so that you can bring back to your cancer care team and ask questions about and talk more about what options are appropriate for you. So treating vulvovaginal changes that have oftentimes negative implications for sexual health, that might come in the form of an over-the-counter lubricant, vaginal moisturizer. For some folks, vaginal estrogen, depending on their medical history, may be appropriate. Pelvic floor physical therapy and dilator therapy to help with the muscles and tissue stretching as appropriate for folks. These are all potential options for care and very important to be aware of and have conversations with your medical team about. Penile changes can be significant, particularly for folks who have gone through treatment for prostate cancer, including radical prostatectomy. So there can be significant changes in orgasmic functioning and ejaculatory functioning. There can be changes in the size and shape of the penis and sensation of the penis. And also important to be aware that there are a number of potential treatment options so that you can speak about these with your care team. So this might range from something like a constriction ring or vacuum device to PDE5 inhibitors, which are medications that can help with arousal and erection, injection therapies, penile prosthesis surgeries, and again, pelvic floor physical therapy can be enormously helpful in helping to restore sexual functioning and health when there have been penile and genital changes in this way. Sensory changes are very, very common. Genital sensation changes are very common with cancer treatment, including radiation and chemotherapy. There are a number of potential treatment options for sensation changes, including exploring sexual aids such as vibrators, exploring kind of body mapping procedures or behaviors alone or with a partner to kind of re-engage and rediscover what those sensations look like at this time. And certainly mindfulness skills training can be enormously beneficial for folks who are navigating bodily changes through cancer care. All three of these treatment options are things that you can discuss with your care team and specifically may be useful to consult with a sexual health therapist or a sex therapist who is knowledgeable about oncology care and the role that cancer can play in shifting sexual health. I wanted to make you aware of several really excellent resources that exist out in the world around this intersection of sexual health and cancer care and treatment. Many of these are written by Ann Katz, who is trained as a nurse originally, but has re-specialized and is now a certified sex therapist and really specializes in working with folks who are having sexual health changes and concerns with cancer treatment. And she has written a number of very excellent books that have been very helpful for patients. A couple of others, one of these is specific to prostate cancer. All of these books you can find online fairly easily. They are great resources for both cancer patients and their partners that are supporting them and going through this journey in their own way. A few other resources here. Cancer.org has a number of websites kind of within the broader website that talks about side effects around sexual health and cancer treatment. Willtolove.com has wonderful education, online forums and webinars about this intersection of sexual health and cancer. And then on the right-hand side here, asec.org and ishwish.org are two places where you can search for sexual health providers, including sex therapists and sexual medicine providers, many of whom are very knowledgeable about helping folks work through sexual health changes with cancer care. In summary, I want to really highlight the importance of comprehensive multidisciplinary care for sexual health concerns. Sexual health is an incredibly important part of your life, regardless of cancer care and treatment. And so it's very important to talk about your concerns with your cancer treatment team. Thank you.
Okay. Well, I hope that was helpful. I really like kind of the more in-depth information about the physiological changes and interventions and that kind of thing. If you're interested, she does have more content in this area. And of course, there was some great resources that Dr. Wenzel named in that video as well. So I will get to the end of my content here, I just wanted to share some of these resources that you can check out if you're looking for more information. So whether it's for yourself, coworkers, clients, families, lots of stuff in here for everyone. A few of these things are specific to Alberta, so I don't know if anybody's joining us from Alberta tonight, but the first one we have is the Alberta Society for Promotion of Sexual Health, or Hospice. They have a full schedule of trainings throughout the year. They're different month to month, so just check their website if you're interested in any of the current offerings. The workshops are held online, so anybody outside of Alberta can also take advantage. There is a cost associated, and that can be up to $85. So those are really great if you have education funding available or anything like that through your work potentially. This next one, the American Cancer Society, has a page about fertility and sexual side effects in people with cancer. Lots of information there with a medical focus. The Canadian Virtual Hospice has a section with articles and videos aimed at supporting queer folks in being able to access and receive inclusive, respectful care. Center for Sexuality, that's another one that's local to me. So they're based in Calgary. They provide kind of a range of services around sex and sexuality. One of those services is free short-term counseling for anyone who wants to talk about relationships, sexuality, gender, sexual diversity, sexual health. They do have a 3-hour workshop for professionals called Integrating Sexual Health into Your Practice. And there's an online learning center that includes a section of sexuality and older adults. I did speak about the Calgary organization Rainbow Elders, and there's a similar one in Ottawa. So they have you have the Senior Pride Network that offers events, education, advocacy, all kinds of things. Oh, sorry. Can anybody hear me? We're still not
I
hearing
can
you.
hear you fine.
Oh, okay. I'm sorry. I just saw that in the chat. I
I
hope
had
that.
messaged Shilafuya. I hope I'm not sure what's going on for them, but I can hear you fine.
Oh, okay, perfect. Okay, sorry. I just get on a roll. All right. I will just skip to the next one here. So these are just the articles that I've referenced during the presentation. If anyone wanted to look into any specific articles or anything, any of the information that I cited, this is where you're gonna find it. I'll just linger here for a moment. If anyone's taking a screenshot or anything, you can go ahead. And then that brings us to the end. So thank you so much. I'm here for your questions and comments. If there's anything we want to discuss.
Yeah, and as I said at the top, if folks do want to put up their hand, I can unmute you. I've got that power. And yeah, you can be unmuted and ask a question. The only thing I'd ask is that if you do ask a question, that you not include kind of any identifying information. So we're getting lots of thanks in the chats there. No questions or comments. Is everybody pumped and they're ready to go out and address sexual health with the people in their care?
Yeah, I mean, I think I repeated this a few times, but truly like the most important thing is just to have those conversations at all. Like I think especially the videos from the people who have been through cancer care really brought home for me, like just to ask. Like you don't have to be an expert, you don't have to have all the answers, but it's an important subject for folks. A lot of people might not have much to say on it, but for the people who it matters to and who want to talk to you about it, it makes all the difference. So
It's interesting because I have when I do talks about a palliative approach to care, like we talk about it being a holistic approach to care, right?
mhm.
And I have this graphic and it includes sexuality or sexual health. I can't remember. I actually put it at one point in the chat because I think you know, and when I present, I often go, and there's sex, and or something,
Sure,
I
yeah.
kind of, skim over it. And I think, it's as much, and I love that list of reflective questions that you shared, Catherine, because I think it's as much about our own comfort. And if we're not comfortable, like the people in our care are not going to be comfortable talking about it. So a couple of, comments, lots of things we take for granted, good food for thought. Recognizing sexuality is part of living and dying. And if we're, in palliative care, we talk about, we provide care for the living till they die. So sexuality is a part of that.
Absolutely.
Aine asked, how can a personal support worker approach this sensitive topic? Any comments on that in their role?
I mean, I think it's the same. Like, I have the same advice for anyone. Like, it really depends on, your relationship with the person that you're working with, how you're gonna kind of approach it initially. But yeah, I do think like the main thing is just to kind of bring up the conversation and say like, I'm here to talk about this, or I'm here to support you with this, and let them kind of guide you from there. Some people may not want anything, and other people might kind of lead you into more of specifics of what they're talking about. Depending on like exactly what the role like PSW, because I know it varies regionally, so I don't know if I'm thinking of the exact thing that maybe you're thinking of, but Eva Sweeney, and that podcast episode on Disability After Dark, like they talk about personal support workers in that episode, so that might be something that would be helpful, and kind of give you a few tips on what to expect.
Another nice comment. I work with seniors and have a few transgender clients in my practice. We all need to be loved and love others. Self-love is important. And so glad that these resources are available.
Absolutely. Yeah, I think that's wonderful. I was like, yeah, the Rainbow Elders in Calgary has some great resources around trans elders is the language that they use, so seniors who are transgender. And I'm sure the Ottawa Senior Pride Network has similar resources if there's anything that you're looking for. But yeah, it's such a wonderful thing to be able to kind of integrate into practice and really honor people's whole self.
Our friend from Zambia, Chulafoya, I hope I'm saying your name correctly. Did you have a question?
Actually, it's just a comment to say, can you hear me?
Yeah, we can
Yep.
hear you fine.
Sorry, my voice is hoarse because it's 2:11 in the morning. Yeah.
Well, thanks for staying up with us.
I think it has just opened and enlightened some of the issues that we take for granted. I have so many examples, life experiences, but I think the sexuality issue needs to be downgraded not only to the patient, because especially in our case, we deal with children with the cancer, sickle cell, and hemophilia.
Mm-hmm.
And we're talking of examples like, what about caregivers
Mm-hmm.
who have been away from the family, left the children, left the husband, and they've got all those feelings with the stress that comes with the looking after a child in a strange environment in the cancer diseases treatment center. What happens? Example whereby I was working in South Africa at the one of the centers where we are looking, it's called the Chalk House. We are looking after the caregivers and the children who come from distant places.
Mm-hmm.
This woman just approached me and said, Can't you look at me? Am I not beautiful enough for you?
Mm,
Eh? Can't you look at me? You can't even just give me a hug.
mm,
What is the problem? So the aspect of sexuality also needs to be downgraded to the caregivers too, how it affects them, how some of the situations whereby, like here in Zambia, we've seen a families getting disintegrated because of the mother has been away for a long time. She goes back, she finds their husband has been married to another woman.
mm,
So those are some of the issues that we need to look at. It doesn't just affect a a patient,
mhm.
adult patient, but also it affects the caregiver. I'm
Absolutely.
dealing with a situation where I'm paying for
Thank you
a
very
male.
much. That's
Okay,
great. You'll
okay.
go to
Yeah.
bed soon.
Yeah. Thank you. Yeah, I think that's a really good point. Most of my presentation, like I've focused on the patient and then kind of said like in brackets and loved ones and family, and because we have the most or many caregivers, or healthcare providers have the most direct contact with the patient themselves, and a little bit more like peripheral contact with family and loved ones. Like that's where I've put my focus, but absolutely like in something like sexual health, like it's a relational experience for a lot of people, right? Um, when you're speaking, I was thinking of the Zen Hospice in San Francisco, and who they run courses for like family caregivers and yeah, close caregivers to be able to care for themselves and find strategies while they're also providing that care to their family.
It's kind of making me think about we have a practical caregiver education program, and we don't address sexuality anywhere in it.
Mhm.
You're now making
Right.
me think, oh, maybe we need to
An
reconsider.
updated curriculum.
Yeah,
Yeah.
yeah. Well, if there's no other questions, nothing's come up in the chat. I don't see any hands up. Maybe we'll close out for the evening, but I again want to thank everybody for coming, and we'll look forward to seeing you at our next Thursday evening series. We did change the date, move the date to the 24th of October instead of the last Thursday of October, which is Halloween. We figured people's homes might be a bit busy. So we'll hopefully see folks on the 24th of October. And again, thanks so much, Catherine.
Yeah, thank you for having me.